Hello, we're going to talk about anxiolytics. This is MSN630 for Alverno. And we're going to get into the neurobiology of anxiety and the specific areas that are most involved in anxiety. So anxiety can be divided into fear and worry. They're different. So when we think about fear, we think about panic and phobias. And these are controlled by an amygdala-centered circuit. Worry, so anxious misery, apprehension, expectation, and obsessions are associated with a different part of the brain, and it involves a circuit that we refer to as the CSTC. That's the cortical striatal thalamic cortical circuit. And there we see the specifics on the slide. Okay, so the next slide, we see the circuit that's overactivated here. We're looking at fear, which I said was related to an amygdala circuit. And so the fear is primarily associated with the amygdala, the limbic system, and the orbital prefrontal cortex. And so what happens when you're afraid of something is your thought process takes off on its own. And when you're thinking about something that you are fearful about, it stimulates the limbic system, and then off it goes into this very difficult to manage circuit. So here we're seeing our gentleman here worrying about his finances. Okay, so is there a genetic component? Absolutely. So it's a mixture of our genetics as well as the epigenetics, the life stressors. And so there is a gene called COMT. COMT stands for catechol-methyltransferase, and COMT regulates dopamine in the prefrontal cortex. And I'm just going to open up this entire slide here so we can better talk about it. So COMT has various genotypes. On the right here, we see the MET genotypes of COMT. And if you have the MET variant, that results in efficient processing in the dorsolateral prefrontal cortex, DLPFC. And so the COMT is working very well, and it breaks down dopamine. And so people who have the MET variant have lower levels of COMT. Then we have the VAL genotype. In the VAL genotype, the VAL genotype has a higher level of COMT activation, and so because there is a higher level of COMT, it's breaking down a lot more dopamine. And so someone who has the VAL variant of COMT will have lower levels of dopamine, and they are better able to handle if they're under stress and the dopamine increases, they're better able to handle that. And so we call them the warrior, which we see here on the left. Again, if you have the MET barrier, these folks have lower levels of COMT. Therefore, not as much dopamine is broken down, and they are expected to have better cognitive functioning. However, if there's a lot of stress, there's too much dopamine stimulating, and that will result in anxiety. So we say MET to worry. And that's a good, understanding the COMT can be helpful if you do gene testing and you look at the person's actual genotype for COMT. Okay, so here we go with anxiolytics that we will be considering. The SSRIs, we have citalopram, escitalopram, paroxetine, fluoxetine, sertraline. Fluvoxamine is not listed there, but that can also help with anxiety and more specifically OCD. The SNRIs can also help anxiety. Effexor, Pristiq, or venlafaxine, desvenlafaxine, and duloxetine. And other anti-anxiety medicines include mirtazapine, as well as buspirone. All of these medications are officially labeled as antidepressants, except for the buspirone. That is specifically referred to as an anti-anxiety drug. So when you are talking to your patient about prescribing them medicine for anxiety and you suggest that you're going to give them Zoloft, they may recognize Zoloft as an antidepressant and so be concerned that you're treating them for depression and not for anxiety. And so you may keep that in mind, and if they look it up, they're going to see, oh, it's an antidepressant. Why is my provider giving me this? So you might want to clarify, these are the drugs of choice for anxiety. So we also have benzodiazepines, and a couple of things to keep in mind. Number one, they are not our first choice in treating anxiety because they are extremely addictive. There was also a study in March of 2015 that showed that long-term use of benzodiazepines increases the risk for Alzheimer's disease. That study recommendations have been reversed by a later study that came out that said that's really not the case. Now, on the other hand, we should be concerned that, especially with our aging patients, that being on chronic benzodiazepines is going to increase their risk of falling and fracturing something. And it can also reduce cognition and their ability to think clearly. And this is something you will want to explain to your patients. You may be the recipient of patients who have been on benzodiazepines for years, and now they are approaching older age, and they're still taking it and feel it's still helping them. And then you come along and tell them the risks, which we are obligated to do. But you may find practitioners who've heard the report from 2015 and believe that it can cause Alzheimer's. That has not been substantiated with further studies. Other drugs we use as anxiolytics include quetiapine, which is Seroquel. You can often use quetiapine in very small doses for managing anxiety during the day. So anywhere from a half tablet of 12.5 milligrams up to 50 milligrams 3 times a day can be very effective for people, particularly those who are not sedated by that low dose. Gabapentin is also an option to manage anxiety. The only limiting factor would be if the person becomes too tired on it. And that's true of all of the anxiety types of non-SSRI or NRI medications, is that potential is to cause the person to feel too tired. But typically you'd start a person on 100 milligrams of gabapentin 3 times a day for anxiety. If it doesn't work at that dose, and as long as they're not sedated, you can go up to 200 and up to 300 3 times a day. I do have a couple of folks who are on 900 milligrams 3 times a day, and they're not tired on it, and that's the dose they need, and it does control their anxiety. The maximum dose of gabapentin is 3,600 milligrams per day. There are also histamine antagonists and adrenergic agents that can help with anxiety. For example, a beta blocker like propranolol. Histamine antagonists would be something like a hydroxyzine or a clonidine. Actually, I believe clonidine's an adrenergic agent. One comment on buspirone: it cannot be used on a PRN basis, and I've seen this several times now, where primary care has prescribed buspirone 5 milligrams and told the person to take it as needed. It's not going to work that way. They need to be on the dose. Almost always, if buspirone is going to work, the dose needs to be pushed up. It should be taken 2 or 3 times per day. And you can start at 5 milligrams 2 or 3 times a day, but I would not spend a lot of time waiting before you increase the dose. So you want to get it up to 10 milligrams 2 or 3 times a day, and then 20 milligrams 3 times a day, or 30 milligrams twice a day with a maximum dose of 60. So if you're going to use buspirone, don't drag out how long you take before you get the dose maximized. And I think that's why buspirone is known to fail a great deal, is that I wonder if the dose hasn't been pushed up to work effectively. Other drugs that are not listed here but have potential to work as anxiolytics would be vilazodone and vortioxetine. Okay, so let's get into a little more of the physiology. Okay, so GABA is greatly involved in the process. GABA, think of the brake system of the nervous system. And so GABA helps slow us down when the anxiety is getting out of control. Okay, so GABA is also the site of action of the benzodiazepines. GABA is metabolized by glutamate. GAD refers to glutamic acid decarboxylase, and then that GABA is transported into a vesicular sac by the transporter, the vesicular amino acid transporter, which is designated here VIAAT. and their GABA is being released. This is showing us how after GABA has been released, how the action of GABA is terminated. So it's either terminated by being transported back into the axon, or it is, and there we see the little trolley there, or it is destroyed by GABA transaminase. Okay, and there it's going back into the axon, and there it was just destroyed by GABA transaminase. Oh, and it's going to do it again. Okay, there are three types of GABA receptors, A, B, and C. The one that we're most interested for our purposes is the GABA A receptor. That's the one that has the major role in anxiety and treating it. And GABA A, B, and C, each of them have different configurations, as we see here on the postsynaptic neuron. There's A, B, and C. So we're going to focus on GABA A receptor complex. And each of these receptors is made up of subunits. Each subunit is formed by 4 chains in the cell membrane. We refer to this as 4 transmembrane loops and cytoplasmic loops. And then different types of the subunits. Oh, I'm sorry. So here's one subunit. So different types of subunits combine to form subtypes or isoforms. And there are 6 alpha. Let's get this slide out. So we've got 5 subunits forming the receptor complex. And in the center is the chloride channel. Okay, so there are different subtypes, as you can see by the Greek letters. So for example, there are 6 alpha A isoforms, 3 different beta and gamma, and so on, different isoforms. And they all do something a little bit different. And so we see here are the GABA binding sites. And we see a benzodiazepine binding site. And the benzodiazepines bind on a different site, and we call that an allosteric site. So depending on how these isoforms combine, the GABA receptors are linked to different functions in the body. And there we see on the other one GABA binding site and the benzodiazepine binding site. So some GABA receptors are located on the synapse, and some of them will regulate anxiety and also boost inhibition. We call that phasic inhibition. Other receptors are located outside the synapse, and they have also different isoform configurations. They are implicated in the sedation effect from alcohol and anesthetics. Okay, so when GABA binds to the receptor, it increases the frequency with which the chloride channel opens. Therefore, there is more chloride and more inhibitory activity. So there's the chloride ions, there's GABA binding, and the chloride channel is open, so more chloride ions go through. Here, we find that when a benzodiazepine binds to the other site, the allosteric site, there you go, we call it a positive allosteric modulator because it enhances the activity of the GABA. Therefore, it enhances the opening of the chloride channel. So the positive allosteric modulator, or a PAM, which is the benzodiazepine, will not activate the receptor by itself. GABA has to be present. And so the benzo, or the PAM, enhances the activity of the GABA. And there you go. The GABA is present, the benzodiazepine is added, and we have that chloride channel opening wide and a lot of it going through. Now, if you get an overdose of the benzodiazepine, that person is going to be heavily sedated and may end up in a coma. And a medicine that's used to reverse the action of a benzodiazepine is called flumazenil. Oops. And then just to back up momentarily from the previous slide, when a benzo has bound to the allosteric site and GABA is not there, that is referred to as constitutive receptor activity. Okay. Now we're going to talk about a hyperactive amygdala and fear. So you've seen this picture before. It's a little bit larger. We have areas of overactivation and areas of normalized activation. So when we have GABA in the amygdala, we see that we have overactivation. The person has fear. And there we see the GABA neuron. So that's where the benzodiazepine would work at. And so when we've got the GABA action, then the fear can go away. Okay, so there are also drugs we refer to as the alpha-2 delta subunits, agents that bind to the alpha-2 delta subunits of presynaptic voltage-sensitive calcium channels will block the excessive release of glutamate in the amygdala. And if we block glutamate, what's going to happen? It will also reduce that glutamate, the impact of that over-excitation from glutamate, and will also extinguish the fear. We also know that the serotonergic agents can also help with an overactivated amygdala. It is thought that a depletion of serotonin is linked to overaction of the amygdala. And so if you enhance the serotonergic activity in the amygdala, things should calm down. And sometimes we end up using a combination of these types of medications to help calm the fear. And when we look at the condition of worry and the hyperactive CSTC circuits, it is thought that these medication options are operating in the same way as they work when we're dealing with fear. So there we have worry, and if we give a benzodiazepine and enhance the GABA, the worry is extinguished. Same if we administer an alpha-2 delta ligand. Worry is extinguished. And if we were to give serotonergic medication, increase the amount of serotonin in that area of the brain circuits to extinguish the worry. Okay, so this is showing us a 5-HT1A partial agonist action in the management of anxiety. Buspirone is a 5-HT1A partial agonist, and it may reduce anxiety by action at the presynaptic somatodendritic autoreceptors on the left and at the postsynaptic receptors on the right. And again, like all of the antidepressants, the onset of action of buspirone will be delayed. And so it is thought that the therapeutic effects of buspirone are related to the downstream changes and not the acute action at these receptors. Okay, so now we've added the buspirone on the slide here. Okay. It's also thought that there is noradrenergic hyperactivity when there is anxiety or fear. And so norepinephrine provides input not only to the amygdala, but to all the regions to which the amygdala projects. So it does play an important role in the fear response. So if you have noradrenergic hyperactivation, that can also lead to anxiety, panic attacks, tremors, sweating, tachycardia, hyperarousal, as well as nightmares. And alpha-1 and beta-1 adrenergic receptors may be specifically involved in these reactions. So the noradrenergic hyperactivity can be blocked by giving an alpha-1 adrenergic blocker. And that can lead to a reduction of the anxiety and stress-related symptoms. Noradrenergic hyperactivity can also be blocked by giving a norepinephrine transporter inhibitor, which can have the downstream effect of downregulating the beta-1 adrenergic receptors. And so a reduction in stimulation of the beta-1 adrenergic receptors could therefore result in alleviation of anxiety and anxiety-related symptoms. So nightmares and hyperarousal are typical of not only chronic anxiety, but even more so of PTSD. Norepinephrine is the neurotransmitter most implicated in physiological arousal, things such as nightmares. And by inhibiting the activity of the norepinephrine, that will result in reducing the physiological symptoms. And so that person will not be awakened by a nightmare in the middle of the night. And we also know that there can be noradrenergic hyperactivity in anxiety and fear. Norepinephrine provides input to the amygdala, but many other areas. But it can also be blocked by a norepinephrine transporter. That can have a downstream effect of downregulating the beta-1 adrenergic receptors. And reduced stimulation through the beta-1 adrenergic receptors could result in a reduction of anxiety. There you go. And this also holds true for noradrenergic hyperactivity in worry. We know that worry can be caused by overactivation of the CSTC circuits. And specifically, if you have excessive noradrenergic activity in these circuits, this can reduce the efficiency of information processing, theoretically contributing to worry. So noradrenergic hyperactivity in the CSTC circuits may be blocked by giving a norepinephrine transporter inhibitor, as we refer to as NET. And that can result in downregulating the beta-1 receptors, which can also lead to an alleviation of the worry. And again, the action is delayed. As we know, this takes a little bit of time. It's a bit of a delay. Just like with all of the SSRIs and the SNRIs. Okay, so this is a funny looking slide where we're talking about fear conditioning versus fear extinction. So the more the amygdala is activated by fearful stimuli, it can be external or internal, the stronger the conditioning or the reinforcement of the fear. The hippocampus remembers very strongly and associates very closely with the fears. So medication can reduce and suppress the amygdala activation, but that's not a cure because the underlying fear conditioning remains in place. What we need is extinction, or what we call reconsolidation, which will extinguish the fear response, not just suppress it. So when a person has a very stressful or a fearful experience, the sensory information is relayed to the amygdala. It's integrated there with input from the ventral medial prefrontal cortex and the hippocampus. And so at that point, a fear response can either be generated or it can be suppressed. The amygdala remembers stimuli associated with the experience by increasing the efficiency of the glutamate neurotransmission. And so any future exposure to the stimuli, a fear response is even more efficiently triggered. And if that is not countered by input from the VMPFC to suppress the fear response, the fear conditioning will continue. Fear conditioning is not easily reversed, but it can be inhibited through new learning. New learning is referred to as fear extinction, and that is the progressive reduction of the response to a feared stimulus that is repeatedly presented to the person without adverse consequences. On the left, we see the fear conditioning. The fear continues, the fear response continues. On the right, we're looking at fear extinction. So that the person does not have symptoms related to fear. So how does fear extinction actually occur? Hypothetically, it occurs when information from the ventral medial prefrontal cortex, the VMPSC, and the hippocampus activate the glutamanergic neurons in the amygdala that synapse upon a GABA interneuron located within the amygdala. So this sets up a fear extinction circuit. That is, there is no fear response in the presence of the stimuli. Over time, with strengthening of the synapse and long-term potentiation in the new circuit, this produces a GABAergic drive that overcomes the glutamanergic drive. And so the pre-existing fear circuitry is extinguished. And when that happens, we know that there's new learning that has occurred and the old learning is gone. One of the things that is being investigated is how to boost the NMDA glutamate receptors in the lateral amygdala that can help with fear extinction. And then we also know that beta blockers can prevent fear conditioning. So when fear is first conditioned, the memory is said to be consolidated via a molecular process. It was once thought that that process was permanent. However, what we are finding is that administering either a beta adrenergic blocker can potentially mitigate the conditioning of the original traumatic memory. And so some research is also now showing that even when emotional memories have been consolidated as fear conditioning, they can change when they are retrieved. So reconsolidation is the state in which reactivation of a consolidated fear memory makes it labile. So protein synthesis is involved in keeping the memory intact, but this may be disrupted by beta blockers. So here we see we are administering a beta blocker, and that is able to knock out the fear conditioning and reconsolidation. It's also believed that opiates can do this as well, resulting in the fear response is extinguished. Okay, so let's talk about benzodiazepines. Lots of stories about the use of benzodiazepines in managing anxiety. I see many patients who come to me who are on, some are on very high doses of benzodiazepines, and they've been on it for years. Some of them are told by their previous provider that their benzodiazepines must be discontinued, and in some cases they are looking to find a provider that will keep them on their benzodiazepines. Many side effects, from sedation, drowsiness, lethargy, mental confusion, motor impairment, cognitive impairments, disorientation, slurred speech, amnesia, and addiction. So let's try to give you a balanced perspective as we go along here. We also know that if given in pregnancy, benzodiazepines do cross the placental barrier. And if it's used in the first trimester, very small risk of problems. But in the third trimester, the babies can be born with some addiction to the benzodiazepine. And it's also not advised if the mom is going to breastfeed. So who uses benzos and who abuses? So the medical users are more likely female over the age of 50 who are using it as prescribed. They typically don't develop tolerance or progressively escalate it. They are seldom at high risk for withdrawal, and they do not constitute any serious medical or social problem. And they are getting the medication appropriately from their doctor. They are not shopping around for a prescription. The abusers tend to be males, ages 20 to 35, and may be using it for a non-medical purpose to get a high out of it. They use it in excess of the guidelines. They do develop tolerance and want to increase their doses. They are at high risk of withdrawal, and this is a medical social problem, and they may shop around to get the prescription or get it illegally. So it might be nice to have an overall rule to prescribe it or not, but you really need to decide to prescribe or not to prescribe on an individual case-by-case basis. So what is the disorder? The duration, severity, is the person using opioids? Is there a history of or current substance abuse? What is the age, personality, style, or character traits? Bottom line, they are effective for anxiety disorders. They generally should be used at the lowest dose and for the shortest period of time possible. They can often be very helpful as a temporary adjunctive medication when starting an SSRI or an SNRI until they start working, in which case you would let your patient know, I'm going to add this for you to use as needed while we are getting the other medication on board. Best to continue on an intermittent, flexible dosing schedule rather than a fixed schedule. And then in cases where you need to get the person off of the benzos, I strongly recommend gradual dose reduction. This can be, and at the same time, you want to make sure you're providing your patient other strategies to help their anxiety. So SNRI or an SSRI, beta blocker, or an alpha adrenergic agent, or quetiapine in low dose, or I think I said all of them. So you want to offer your client as many options as possible, including participation in counseling and therapy to help them deal with the anxiety or extinguish the fear conditioning. If you are faced with a person on high-dose anxiolytics, there are varying ways of weaning folks off of it. One of the well-known strategies is called the Ashton Protocol. ASHTON, Ashton Protocol, which if the person has been on high-dose alprazolam for a long time, the Ashton Protocol will use diazepam and will switch the person to diazepam and then wean them off of the diazepam, because it is much easier to get off of a long-acting benzo than a short-acting one, such as alprazolam. So it can make a very nice difference. But again, while you're doing that, you need to get them on more effective medicine and therapy to help them with the anxiety. Patients can be very difficult to engage in treatment to do this, and I think it makes a difference if you have a good relationship with your patient and that you present this in a gentle way, because many of these folks are from a different era where this was appropriate, and they had a doctor or a provider that they trusted that gave them this for many years. And so this can be a very difficult message to give to your patient, and one that they do not expect at all. Another comment I would like to make that I should have mentioned earlier and forgot. I've seen many patients come to me who have been receiving treatment, usually by a primary care provider, but sometimes from a psychiatric provider, and they've been given bupropion or Wellbutrin. And let me tell you that for most people, Wellbutrin does not reduce anxiety. It very likely will increase anxiety. And yet I've had folks come to me who are insistent that the Wellbutrin has helped their anxiety. And I have to wonder if there was also some concomitant depression going on that reduced the depression, and in turn, perhaps they felt less anxious when they were feeling well. But if you are faced with a patient coming to you complaining of anxiety and they're on Wellbutrin, 300 milligrams, you might start reducing their dose of Wellbutrin to see if that makes a difference, and making sure they don't become depressed. This is a quote that I think is very important and is worth thinking about. Consider this. Some patients' quality of life, however, may depend on the long-term therapeutic use of a benzodiazepine. Although periodic attempts to discontinue medication should be made, to determine whether return of anxiety represents a withdrawal reaction or a reemergence of the original disorder, categorical withholding of benzodiazepines may do more harm than good. For example, some may turn to more dangerous drugs in an effort to obtain relief, and others may seek a more permanent solution through suicide. And so this is a caveat against having too harsh a stance against benzodiazepines. I have known of students who have said to me that when they are in practice, they are simply not going to administer or prescribe a benzodiazepine. And if that is your thinking, I'd encourage you to reconsider that process. If you've ever had or known of anyone who has experienced the misery of a panic attack or severe anxiety, the benzodiazepine can be an amazing medicine to allow that person full function of their life. And it would be simple and I know there are providers who simply will never give a benzodiazepine, and I really think that's kind of a cop-out from making the hard decisions of who is appropriate and who is not. And if you couldn't possibly help manage that person's anxiety level by a low PRN dose of a benzodiazepine. So with that in mind, here are some practical tips for prescribing. Have an agreement, a written agreement. I do that in my practice, and patients sign that they will keep the medicine safe, that they will not mix it with alcohol, other drugs, particularly opiates, that I will do periodic lab testing to ensure that they're taking it and not giving it away or selling it. I have to be the only prescriber. If they lose it, they do not get refilled early or a different version of the benzo. And we find that pharmacists today have a role in whether or not the benzodiazepine will be prescribed as well. And so it is important to be reasonable. I have on a first-time situation where I've treated someone for a very long time and something happens, perhaps they are moving in that case and lost their bottle. Perhaps it would be appropriate on a one-time basis to refill them early, but there would be a number of factors that I would consider. If this was a person I had been treating for years and who had been very consistent with their medication, perhaps they did lose not just the benzo, but all of their meds in a move, for example. But in general, I will not prescribe early. I also will not use a benzo as a monotherapy, except if I'm giving a person 10 tablets a year to get in when they have to fly somewhere to get on an airplane. I also have one patient that uses benzodiazepines before medical procedures. This patient has a history of ovarian cancer, which she has fought and won, but she still has severe anxiety if she has to have a medical procedure. And so I do give her a small amount of Valium to use even before she has to go and see her oncologist, because I believe there's some PTSD there, recalling her diagnosis of ovarian cancer and all the treatment she went through. So those might be cases where I would give a small quantity of a benzo to use for a specific reason. And of course, you need to be firm and consistent with whatever guidelines you decide upon. And so what if you do have someone who comes to you, they're on high dose benzo, maybe they're on 2 of them. It's important to build a relationship with your client, check the PDMP, explain the process of what you're going to do, and do so gradually, and make sure you get them into some supportive psychotherapy as well. So here is the generalized anxiety disorder pharmacy. Benzos are included in all the first line approaches. They should be used adjunctively for short-term use, and you should inform your client of that right away. There are SSRIs and SNRIs that can be activating, especially in the beginning. Prozac is known to be activating when first started. And so those should be used at lower doses for anxiety. A second generation antipsychotic could be used for the sedating effect. Cognitive behavioral therapy would also be used along with a pharmacological approach. And some of us think that should be in the first line approach. So here we have in the first line maybe a benzo temporarily, an SSRI or an SNRI, alpha-2 delta type medication, buspirone, make sure you're using it correctly. And I would add CBT to the first line. Second line, the SPA-RE refers to a specific serotonin type medicine. Tricyclic antidepressants have been used. Mirtazapine can be very good if issues with weight gain and sedation are not a problem. Trazodone, more particularly if sleep is the bigger concern. And SPA-RE, I'll let you, if you can't remember that, I'll let you check what drug that refers to. It does stand for serotonin partial agonist reuptake inhibitor. And then third line, like I said, I'd move CBT down a couple of notches, but you can consider a hypnotic and an atypical antipsychotic such as the quetiapine. Here is the pharmacy for panic. Second line, MAO is also maybe considered. Of course, you would have to get them off of the serotonin drug. Social anxiety. For some reason, the benzo was moved to the second line, and the beta blocker is second line. I've used beta blocker more as a first line. And we also see the addition of naltrexone and acamprosate, which are 2 drugs used in the treatment of alcohol cravings and alcoholism, as well as opioid addiction.